slide. And my objectives today, following in the heel of the high frequency jet ventilation talk that Dr. Klein did 2 weeks ago, is to really focus on a little bit more details about the parameters that are relevant for pulmonary mechanics. Also kind of looking at what different devices are available worldwide for delivering high frequency oscillatory ventilation, even though in the United States there's only one. Understand what the core mechanisms are related to high frequency oscillatory ventilation, as well as kind of go through some case examples, and then talk about what are the current outcomes, comparative outcomes for different modes of ventilation, specifically for the preterm population. So just as a background, HFOV was first described in 1915 by Henderson and colleagues. I'm sure many in the room have already heard about the story about the panting dog and the question about how could they sustain ventilation and oxygenation at such a supraphysiological respiratory rate, as well as tidal volumes that are really comparable to anatomic respiratory dead spaces. And based on that observation is how Henderson and colleagues further went ahead to do some of their experiments way back when. So as a side for the fellows, observation and curiosity is very important because you never know when you will find the next breakthrough in clinical care. Obviously, since then, the field has advanced tremendously, and with the intention of minimizing the occurrence of ventilator-induced lung injury, specifically for the ELBW infants. And so when we are thinking what are the goals of ventilation for neonates in general, we are thinking of gentle ventilation strategy. And what are the components of that, no matter what mode you use? They include first of all, volutrauma, so preventing excessive tidal volume deliveries to the fragile lungs or developing lungs. Barotrauma, so the intent being to not deliver excessive inspiratory pressures, MAPS, because that would lead to shearing injury or insult. One that we don't talk a whole lot about, but it is equally important or more so important than the other two, is atelectro trauma, where an under recruitment of the lungs or constant opening and collapsing of the alveoli becomes a big issue. And the three together then combined lead to biotrauma, wherein there is the cascade of release of all the inflammatory mediators that ultimately will lead to the local as well as systemic inflammatory response. And once that cascade starts, it's kind of very difficult to back off from it and minimize the insult down the road. So before I jump into the HFOV concepts themselves, I think certain pulmonary physiology and mechanical physical information is important for this group to understand, because that's how you translate the high frequency mode of ventilation into real time. Time constant, when we are looking at in relation to lung mechanics, equates to the time it takes to either deflate or inflate the lung by 63% after a stepwise change in pressure has happened. And to achieve an equilibrium value of 95%, usually you have to go through three different time constants or three consecutive time constants to get to that state. Time constant is a reflection of both resistances as well as compliances of the lung. So TC is equal to formula-wise compliance times resistance. And when you're thinking of it clinically, obviously you're not measuring these time constants, but you've got to know that a shorter time constant will be associated with low compliance, and long time constants are going to suggest high resistance. And knowing those will and how they impact or how the lung disease impacts those time constants will help you determine what settings you want to put on the ventilator that you're using. A normal healthy lung, the expiratory time constant is about 0.5 seconds. So in about 1.5 seconds, you would have nearly emptied out your entire lung. And the schema on the right side of my screen is just kind of showing what happens during exhalation as well as during the inspiratory phase. Looking at time constant in relation to lung health and mechanics, healthy lungs are pretty homogeneous. So overall, it's assumed that there will be just one single time constant for you and me when we are not in a diseased state. However, when you have lung disease, be it your parenchymal lung disease or your tracheobronchial tree disease, there will be varying time constants for that lung. And it becomes relevant when you're trying to deliver the tidal volumes to areas which have different time constants, and how do you kind of balance that out, or how do you make the most of your strategies to impact that. During respiratory pauses, there will be some redistribution of air that's going to happen between the different units that have different time constants. And during those times, there will be mixing of air that's happening, but not necessarily any changes in your delivered tidal volume. And this phenomena is called penduloft. Basically, what penduloft means is that there is going to be displacement of gas that is present in the non-dependent region of the lungs to the less recruited dependent region of the lungs. And you'll see that how it becomes relevant in a couple more slides to high frequency ventilation. In general, the phenomenon of penduloft will add to lung inefficiency as well as will lead to ventilation perfusion mismatch. So it's generally not a good space to be in, specifically if you have big pauses between inspiration and expiration, but it can be leveraged to deliver volumes or have better diffusion during the high frequency mode. So, few other things relevant to pulmonary mechanics. We know many of us have heard the term lung compliance, obviously, right? We say it's the change in volume in the lungs for a given change in your transpulmonary pressure. And that transpulmonary pressure is the difference in your intrapleural pressure or the pleural space and the alveolar pressure. In neonates, in adults, it comes from both the tissue as well as the surface tension. But for newborns or neonates in general, lung compliance is mostly a function of surface tension. And that's where the role of surfactant comes in. Lung resistance on the other side is expressed as your change in pressure per unit flow. And you're going to be measuring that typically in centimeters of water per liter per second. The lung resistance will depend on lung volume. It'll depend upon the bronchial muscle tone, and then the dynamic airway compression that's happening. So obviously, smaller the lungs, narrower the caliber of the airways, poor bronchial tone, all of that will increase lung resistance, which is what we find in our ELBW, VLBW population. Lung elastance, that is a measure of how quickly or easily can the lung recoil back to its resting position after sustained inflation that has happened. And it is conferred, again, primarily through the elastin that's present within the alveolar walls. And as expected, the lungs are going to be way more elastic than the chest wall itself, because the respiratory system obviously is not just lungs themselves, right? You have to look at the entire system, including the chest wall and your muscles of respiration together. Lung inertance, this is the ratio of change in pressure that is occurring because of the acceleration for simultaneous changes that are happening for volume acceleration. So think of it more like compliance, but flipped over. And you are adding the flow parameters in here, and that is where the acceleration piece comes in. This is occurring because lungs, chest wall, and intrathoracic gases, they all have a mass. And if they have a mass, then there is going to be some changes in the velocity or in the delivery of the flow of the gas. And it can increase your resistance overall. So typically in newborns, we do not factor inertance when we are coming over for our calculations for resistance and compliance of pulmonary mechanics in general, but it is a very important concept which should be included when you're looking at if you're trying to do the studies related to pulmonary mechanics in newborns or infants, or if you're trying to figure out how best to provide support for the kiddos. The concept of resonance lung frequency is again crucial for high frequency modes of ventilation because, again, we are doing a much higher frequency delivery through whether it's high frequency jet or the oscillator. But the resonance lung frequency is the frequency at which the inertance will increase to a point wherein they are going to cancel each other out. So there's going to be a canceling of the inertance and the elastance components. And at that point in time, you will have the most optimal tidal volume delivery for the given set of lungs. In humans, the resonant lung frequency varies between 5 to 20 hertz. Adults, usually we say we live at about 5 hertz, which is again way higher than what we normally breathe at. And for children and infants and very low birth weight infants, the younger they are, the smaller they are, the higher that resonance frequency is going to be. So keeping those concepts in mind, we're going to segue into the oscillatory ventilation. And there are 4 types of current ways of delivering high frequency ventilation in newborns. And I'm now going to focus on the jet ventilation or the high frequency through conventional ventilation or the high frequency nasal ventilation, which has become a little bit more popular in some units. I'm just going to primarily focus on the HFOV. This is just a diagram to kind of demonstrate what happens to the gas delivery of flow as it goes through the trachea and the proximal airway to the point when it gets to the distal airway and the alveoli. When you're comparing conventional mechanical ventilation with high frequency oscillatory ventilation with the jet. So as you can see, for conventional mechanical ventilation, there's no damping. Your amplitude is fixed. You've set a given mean airway pressure. So that bulk flow is going to be delivered right from the trachea into the distal alveoli. And that is where the insult of barotrauma, volutrauma, and all is coming from. When you look at where the waveform is being delivered in high frequency oscillators, it is moving along the central map that you have set. So your mean airway pressure is fixed. That is delivered all the way down to the alveoli without any dampening happening. However, the amplitude between the trachea at the tracheal and proximal airway level will get pretty much dampened at the distal alveoli and airways. The dampening is going to be much more significant once the lung compliance improves. So this is something to again keep in the back of your mind, that the attenuation of the oscillations is directly related to the lung disease that you are seeing. And then when you're comparing it to the jet is delivering your flows around the peak that you are setting. So for them, the peak is fixed, the amplitude will attenuate over time, and the mean airway pressure also will decline by the time it goes from the trachea to the distal alveoli. So what you're setting at the ventilator or the jet itself is not what is ultimately getting down to the alveolar level. This is just demonstrating what Henderson and al. Did and how high frequency flows actually work. So in this smoke experiment they did in 1915, way back when, they blew smoke through a glass tube. And what they were able to see was this nice, beautiful jet in the central part, and then a slower pathway of smoke following along the lines or the edges of the tube itself. When they blocked the tube, or where there was a pause in the flow, all of a sudden the diffusion process kicked in and there was complete mixing of the gas. So that worked beautifully well. And then if they pulled the gas back, they were able to see exactly the same thing happen, but in the reverse direction. The beauty of it all was that even if there was a deformity in the tube, it didn't matter to the flow. The flow still went the way it was going to go, and not necessarily getting perturbed or disturbed by any misshapenness within the tube itself. And this is relevant when we're talking about air leak syndrome such as PIE, and why a high frequency mode usually will work way better in those scenarios as compared to the conventional mechanical ventilation. So core principles for high frequency oscillatory ventilation are basically these four concepts. You are going to be delivering tidal volumes that are really much smaller than the alveolar dead space. And you are doing this at very, very high frequencies. The frequency in HFOVs are much higher than the jet, as you all probably already know. Because at jet, we are only achieving a rate of 270 to 450, depending upon A, what unit you work in, B, what disease process you're dealing with. But the oscillator is actually delivering frequencies in much higher, or breadths at a much higher rate. The uniqueness of the oscillator is that the piston or the oscillating diaphragm is providing both rapid oxygenation as well as ventilation. And this currently is really the only mode wherein you have both active inspiration and active expiration, which again becomes important when you are dealing with areas that have different time constants and where you do not want the gas to just stagnate and cause over distension. The oscillator also delivers really high mean evap pressure for lung recruitment, but at the same time, because it is kind of flowing around a set map, which is still way lower than the set FIP on the conventional ventilator, there is minimizing of the shearing injury that's happening at the alveolar level. The different devices that are currently available worldwide are listed here. I'm not going to go through all of them, but relevant to our talk and for United States, we really only have the Sensor Medics 3100 A or B available in our units, and that is probably what many of you are used to using. The Draeger Babylog 8000 Plus is a hybrid ventilator that is available in European countries, and basically it easily goes in from conventional mode of ventilation into the oscillatory mode of ventilation. So it has its benefits, but it also has its limitations because it really cannot do the core flow pathways that the oscillator actually does. So in comparison to the oscillator, it's a pretty good machine because it can give you other parameters, but it does lack some of the benefits that the oscillator itself provides to us. So when you're thinking of the oscillator, these are the ways that gas transport is happening and gas exchange is happening. Obviously, as I mentioned earlier, there's a mean evap pressure. You are looking at the forward flow in time, and the amplitude that you set will determine the delivered tidal volume for CO2 clearance. And this amplitude, actually, the waveform changes depending upon whether you're doing a 1-to-1 on your I time, 1-to-2 on your I time, or 1-to-3 on your I time. The different ways of improving ventilation perfusion mismatch within the oscillator is, again, going back to the different modes of flow I was talking about. The first one is pendula. So if I have an alveoli that is diseased and has poor lung compliance, and I have an alveoli that is has better compliance or normal compliance at a normal time constant, then some of the movement of air that's going to happen in that quick pause between the piston stopping and then pulling back again, that's the pendulum mechanism, and that allows for the diffusion of the gas between these two alveoli, equilibrizing the volume of that alveoli or recruitment of that alveoli, plus also minimizing the VQ mismatch. The second method of gas exchange is the convective transport of gases. So this is the transport of gas into the alveoli that is happening after the vacuum that's been left from the absorption of oxygen in the capillaries. So that would be your second way of gas transport. The third mechanism is the one that is called Taylor dispersion, which means that the oxygenated gas is passing from the central rapid jet into the deeper bronchial tree. And the way the oxygen diffusion occurs depends upon actually the FiO2, because higher the FiO2, that impacts your Taylor diffusion. The molecular diffusion or the actual gas exchange obviously is happening at the alveolar and the capillary endothelial level, and this is where majority of your gas exchange is going to occur. Then obviously in the bigger airway, there is still some degree of air exchange happening with the turbulence that's happening within the tracheal or the bronchial tree itself. So when you're thinking of the oscillator, I really love it because it's a very simple machine. There are 4 things to look at, and then you play around with them. This is just a schema of what the oscillator looks like. When I'm talking to our group here, I just divide this into a half, right? This half is where my map is sitting, and I'm going to play around with these numbers if I'm going to be focusing on the oxygenation part. And then this half is looking at my ventilation or CO2 clearance using the delta P or the amplitude, the hertz or the frequency that's set, and the I time. Now, in the oscillator, the I time is a percentage. So when you see this 33, that's a percentage of time of the entire cycle, as opposed to the actual measures in seconds or in real time that happens for in the conventional ventilator or on the jet. So this is something to also keep in the back of your mind when you're doing the 1:1, 1:2 calculations for the setting. So for oxygenation, again, it's primarily going to be a function of where you're setting your mean airway pressure, because by recruiting the alveoli, you are minimizing the ventilation perfusion mismatch, and you're also minimizing the intrapulmonary pulmonary to systemic shunt, more commonly called right to left shunting. So shunting away from the lungs into the systemic circulation. For the purposes of improving your oxygenation, majority of the times you'll say keep on increasing your MAP by 1s to 2s, and then look at what is the FiO2 requirement as the lung is being expanded. Obviously, you're not doing multiple X-rays every minute. You're going to get an X-ray at baseline to know where you want to start. Then you're going to gradually recruit the lung to a point where you're just at the point of overinflation, and then you back down a bit. The way you know that you hit that point is more clinical, because as you've increased your MAP gradually, your FiO2 requirement will slowly come down. And then once you go beyond the optimal lung recruitment, the FiO2 will start creeping back up again. And that's the point to say I need to back down a bit more because I'm causing overdistension now. And also, occasionally, if you're just starting too high, it could be that the baby really didn't need that much MAP, and you've just kind of gone significantly up and compressing the venous return, and that isn't a problem. You'll be able to pick that up pretty quickly once you get a chest X-ray and where your heart is completely squished and your diaphragms are completely flat. As I was mentioning earlier, the percentage of inspiratory time is a setting which will determine how much the piston is going forward in inspiration. And majority of the times, many of us don't even look at it, right? We say, it's a set at 33, I'm just going to leave it there. A big mistake, because you can actually play with the I time so that you don't really have to go on much higher numbers for either your MAP or your frequency or your amplitude. Your IE ratios can be 1:1, 1:2, 1:3, but then when you're doing that, remember that your hertz is going to be changed. For a 1:3 combination, my hertz cannot go over 10. Otherwise, I'm really limiting my inspiratory cycle at that point in time. On the oscillator, again, when you're thinking of ventilation, again, this is pretty basic. That frequency is hertz times 60. The range is 5 to 20. So you can hit as high as 1200, 1800 on your rates that you're delivering. If you're changing the frequency, that is going to be inversely proportional to the amplitude and the volume that you're delivering for your tidal volume. So keep in mind that playing with the amplitude and frequency, they go in opposite direction. And more importantly, your frequency that you're picking up for a given patient, you should try to match it to the resonance frequency of the lung at that given age. Plus, you have to also factor in what is my compliance and resistance. So smaller babies, try using a hertz, even start at 15. I've given a range of 12 to 15, but 600 grammer I'm putting on the oscillator. I want to start with the higher frequency so that I can get away with the lower delta P. On larger babies, try lower frequencies. So 8 to 10 would be the range. And obviously, if you're going to try to blow off CO2, you are going to drop your hertz down. For the amplitude, which is a measure of your change in pressure, you are going to determine the amount of power that is driving the oscillator piston forward and back, and that is the total tidal volume that is being delivered. Again, we don't measure tidal volume on the high frequency modes, be it the jet, be it the oscillator, like we do in the conventional ventilation. But if based upon the frequency that you're ventilating at, you can kind of guesstimate how much tidal volume is being delivered. Because at about 5 hertz, you're delivering 3.5 ml per kilo, and at 15, you're delivering about 1.5 to 2 ml per kilo for a given child. So you can kind of make a rough guesstimate of if I am at this hertz, this is the tidal volume that I'm delivering to this child. And based upon your sterile gases, you'll be figuring out how you want to tweak the amplitude or the frequency. Obviously, to blow off CO2, you're going to go up on your amplitude. If you're using the oscillator purely for oxygenation purposes and you are overventilating the child, then you can easily bring down the amplitude to as low as 12 to 16 and still ventilate them just perfectly fine. Majority of indication for the oscillator use, again, just classifying or breaking it down into preterm and term infants. For preterm, some units will use it as a primary mode of ventilation to decrease the incidence of chronic lung disease. In other places, it's used as a rescue mode for the similar population when other modalities have failed. Or if you have severe BPD, that could be an indication for the oscillator use in older babies, or if you have air leak syndromes, such as PIE. But again, if you have air leak syndromes and you have access to the jet, then ideally you should be using the jet. If you don't have a jet and you only have conventional ventilator and the high on the oscillator, and you have a baby with PIE, then this is the baby that you want to give the least tidal volume in. So you're going to try to decrease your amplitude, decrease your MAP, as well as see if you can get away with the lowest frequency possible. And then just sit tight. Give it a little bit long, a few days to sometimes up to a week for that PI to resolve before you can back off further or go to a non-invasive mode. In term infants, congenital anomalies, so kids with congenital diaphragmatic hernia, Porter's sequence, that's where the majority of oscillator use occurs. If you have obviously parenchymal lung disease, and these are usually all your aspirations, right? Meconium, blood, amniotic fluid, or pneumonia. And if you are dealing with persistent pulmonary hypertension of the newborn, sometimes it's idiopathic, sometimes it's related to the parenchymal lung disease that you're dealing with. So those are the most common indications for the use of the oscillator. Monitoring on it. So obviously it is a pretty powerful device. If you're going to put a baby on the oscillator, make sure that you have done monitoring for a couple of different things. You need to be very vigilant about gas exchanges because you can be pleasantly, unpleasantly surprised by blowing off CO2 too rapidly. Be ready to get serial blood gases. Look at your pulse oxes for the units that do use TCOMs. They are a great resource so that you're not really doing a lot of phlebotomy on these tiny babies. For lung volumes, currently we only have chest x-rays as a marker of optimal inflation of the lung, and that's very crude actually. Because many a times you're sitting there and you know that your lung is atelectatic, but you're sitting at 8 to 9 ribs, so you're being told don't go higher on your mean airway pressure because you're at 8 ribs. Doesn't matter. You first need to recruit those alveoli, get the compliance to improve, and then back off. So you may need to go higher on your maps, even if your x-rays are at 8 to 9 ribs, knowing very well that once you have recruited the lung, you are going to back down again. Lung volumes, and I'm going to show you a couple slides down the road where there are ways of assessing and measuring lung volumes, but they are primarily sitting in the research phase right now. They're not easy enough to pull into clinical usage. You can use respiratory inductance plethysmography or the electrical impedance tomography, but again, those not have translated to bedside quite yet. It is also, we are so focused on just looking at gas exchange and lung volumes on the oscillator from the respiratory aspect that we forget that hemodynamics also play a big role in gas exchange when you're on the oscillator. So make sure you're looking at your heart rate, your blood pressure, be it central or just a cuff pressure, looking at your output. You can get functional echocardiography because that can give you an indication of how the heart is performing in relation to the lung and does it need support to be able to maintain that ventilation perfusion matching. Because the oscillator can only do the ventilation part of it. The perfusion still has to come from the heart. So that can actually help you a lot in determining where you need to go next if the baby is not improving just by the conventional monitoring tools that are available to us. Weaning on the oscillator. This totally depends upon the gestational age and the disease process that you're dealing with. So spontaneously breathing preterm infant who just had significant RDS because of just prematurity, lack of antenatal steroids, those babies, as well as the kids who have PPHN, they can actually wean pretty quickly over hours to days because the lung disease improves. It improves the compliance improves, so you can back off quite quickly to get to a non-invasive mode. And obviously, we have interventions to support for those disease processes. Ventilation is just one, or the respiratory management is just one, with the surfactant therapy, or if you have PPHN, INO to cause the vasodilation happen, improves the disease process, so you can back off rapidly. Kids, where you're kind of going to have to take a pause, which is difficult for us, right? We like to do something every day. We get a gas, we want to make a change. So don't get gases. I'm joking. Just get them as relevant to the care that you're doing. But kids with BPD or PIE that you have placed on the oscillator, you have to be really patient with them, and they can take sometimes days, maybe a week to 2 weeks before you're able to back off. And that is important because you're not doing anything is allowing that lung to heal, and so that when you're ready to pull the tube out, the kid will actually successfully transition. So when you're weaning the map, try to get to a level that is at par with where you can then go to a CPAP mode. Many times it comes on discussion on rounds whether do I have to transition the baby from the oscillator to the conventional to then go and extubate the child? And the answer is no. You can just stay put on where you are because The map on the oscillator is just a version of CPAP that you're delivering through the ET tube without the child having to struggle, because obviously you have active inhalation expiration going on. So once your map is down to anywhere between 7 to 10, feel free to just pull the tube out, because then you can transition that kid to CPAP alone at about 6 to 7 or so. Obviously, the kid has to be spontaneously breathing, has to be able to maintain the patency of the airway. And then when you're weaning the amplitude, again, bring the amplitude down as low as possible to a point where the baby himself or herself is now able to take care of the CO2 clearance. And so usually, again, depending upon the gestational age or the weight of the baby, you could easily extubate from an amp of anywhere from 12 to 20. This I thought would probably illustrate some of the points that I was trying to make. So in this case, this is a baby who is a 24-week infant, precipitous preterm labor, did not get the benefit of antenatal steroids, 600 grams at birth, ET tube is in good position. The baby already did receive 1 dose of surfactant in the delivery room. And was currently, at the time of getting this film, on volume guarantee conventional mechanical ventilation. Couple of things wrong with this X-ray. The UA is too low and the UV is too high with the cardiac cath, but we'll ignore that for a second. Looking at just the lung disease, this is severe RDS. This is completely plain, simple RDS, homogeneous lung disease. You are on the conventional mode of ventilation. You can keep on playing with your regular SIMV, but the point is that you're going to use a much higher pressure on this child to be able to recruit those lungs before you can go for that second dose of surfactant, because that's absolutely going to happen in this scenario. But in the meantime, given that you're on 70% FiO2, you are on, you're not oxygenating, you're not ventilating, this is an ideal case to go on the oscillator. And again, I'm talking about the fact that at your unit, you don't have jets. People can do either. I'm not necessarily saying you have to do oscillator here, but this would be a disease process that would respond beautifully well to the oscillator. Again, this is a 3-month-old, 22-week infant. The X-ray is representing that after having been on CPAP for a bit, all of a sudden the kid decompensated. FiO2 went up, the kid got intubated, placed on, again, volume control ventilation. Your SATs are okay, 85 to 92, but it's on a lot of oxygen support, and you are not ventilating. The X-ray here is just demonstrating what many of us have seen, pure bad chronic lung disease, totally non-homogeneous lung disease here, but not amenable to conventional mechanical ventilation. So in a scenario where you do have the jet available, this would be a kid that would respond very well to the jet. But if you don't have the jet, then this is a kid where you could easily get away on the oscillator with 1:3 ratio of the high time. Try to get away with lower mean airway pressure, lower frequency to give more expiratory time, lower tidal volumes being delivered. And that strategy will buy you time for a lung healing. And if you're planning on doing steroid course or something, it'll help you tide over to that time point. This is a scenario of a 2-day-old, 36-weeker infant of a diabetic mom, was on CPAP, but now the FiO2 has gradually crept up, is up to 90% FiO2. Your preductal sats are suboptimal. The kid has continued increased vocal breathing. Prior to this film, a dose of surfactant has been given, and that is your gas. So you're again not oxygenating, not ventilating. This is pure homogeneous RDS due to surfactant deficiency, and will respond quite well to using the oscillator. In this scenario, it's a 2-day-old, 39-weeker meconium stain amniotic fluid was on CPAP, now on 100% FiO2, and you clearly have bilateral air leaks. It's not projecting as well, but I'm assuming you can see that there is pneumomediastinum plus bilateral pneumothoraces. Again, if you have the jet, this would be an ideal kid to go on the jet ventilator. But this is another kid who could beautifully improve just using the oscillator with low MAPs, bigger IE ratio, or 1:3 IE ratios, and lower frequencies starting at 8 to 10, giving more time for exhalation. This case is a 6-hour-old, 38-weeker infant who was known to have congenital diaphragmatic hernia, is on SIMV volume guarantee. It's pretty clear, pretty significant left-sided CDH. And you were called to the bedside because there was an increase in FiO2, and the kid's now on 80%. SATs are, again, suboptimal. Well, for a CDH, they're not bad, but on 80% oxygen, they're not optimal. And the kid's also not ventilating. Since you are already on SIMV with appropriate settings and that's not working, this is a kid who will actually respond quite well to the oscillator, because at this point in time, if you do the calculations, the kid has a higher OI, and you want to probably add nitric at this point in time for pulmonary hypertension. And the oscillator, the way the flow with the oscillator happens, the INO delivery is much better. So you probably want to transition this kid to the oscillator at this point in time. Those were my 5 cases that I want to share. So what is the evidence behind one versus the other? What practices exist and what has data demonstrated? I really love this paper by Sindler and all. And the reason I really like it is because it very clearly shows us the evidence that no matter what device you have in hand, if you're using it judiciously for the right patient in the manner it's meant to be used, one is not necessarily better than the other. So in this paper, they were looking at infants who are born at 22 to 23 weeks, requiring active resuscitation with 3 different strategies. So in Uppsala, Sweden, the primary mode of ventilation for these kids is volume-targeted ventilation. In Japan, the oscillator is the primary mode that they use if the conventional ventilation is not working. And then at Iowa, we've all heard they are a big jet group and have had really good success with it. But the bottom line is that, and this is quote directly from the paper itself, that irrespective of the fact that in 3 different sites, using 3 different ventilators, the outcomes were pretty much similar as far as mortality and morbidity goes for this very, very vulnerable population of patients. And then just kind of looking at where does the oscillator sit when you're comparing it with the conventional ventilator or the jet for the purposes of long-term outcomes. And this becomes tricky because we are all trying to aim and decrease the rates of BPD. And despite all the advances over the years, for the less than 27, 28 week population, the rate of BPD has not budged a whole lot. And that kind of tells us that there's something more than just the ventilatory strategies that impact those outcomes. So using BPD as an outcome measure may be not the best measure when we are comparing different strategies. So looking at this, the first meta-analysis that was done by Cools and group with my mentor, Dr. Courtney, in there. She taught me everything about the oscillator. They really found no difference. They pooled the trials. I think they looked at 18 clinical trials, and they really did not find any benefit of the oscillator versus the conventional ventilator in preterm population. But more importantly, there was no downside to it, because one of the concerns earlier on, when centers were starting to use the oscillator as a primary mode of ventilator, was that there was concern of increased IVH, and they did not find that. There is some data still that does show that air leak syndromes can be slightly higher on the oscillator, but that is a function of the user, not the device itself. If you have poor compliance, if you have high resistance and you are not tweaking those settings to adjust for those, you will end up with air leak, and that could happen no matter which device you're using. Cools and all then went back again. So the first time they did the meta-analysis, that was in 2010. They then went back again in 2015 to redo the study. And in this particular group, they found that there was a slight increase or slight benefit for the oscillator as compared to the conventional ventilator. But they did put a word of caution, suggesting that there could be other factors where the slight improvement was coming from, and so be cautious about interpreting their finding. But again, the bottom line was that the oscillator was not necessarily way better than what the conventional ventilator could do, specifically now that we do have volume controls available in the majority of our ventilators. The other work, which is again looking at the oscillators versus the conventional mechanical ventilators for congenital diaphragmatic hernia, was the Vicky trial. And, I've been doing this for a few years now. So some of these kids, when they were admitted to the NICU, the conventional way of doing things was get them on the oscillator, start them on the nitric, recruit the lungs, and that was the way to be. And actually, that necessarily is not true. You can take care of obviously there's a range and variety, right? So for many of the babies with CDH, you can actually manage them very well on plain simple conventional mechanical ventilation. Some of them, yes, you will have to transition to a high frequency mode, and yes, some of them will end up on ECMO based upon the lung disease. But majority of the babies will do quite well on the conventional mechanical ventilation and actually have better outcomes. That is what they demonstrated in the Vicky trial. Itavianol in 2016 wanted to really compare the jet with the oscillator for the outcomes, and they couldn't do it because there were no clinical trials comparing the two. So if somebody has an interest, maybe it's time to do that comparison and see whether there are differences. The other study that I put up there is looking at the oscillator versus the conventional ventilator, and this study was done by Sun and al. They actually did find a difference in the outcomes, favoring the oscillator for pretty much all the outcomes that they were looking for. But they had a small subset of patients in their study. Similarly, recently, the work that was done by Salvo and all, they were comparing, they looked at a subset of patients. They only picked up the kids who were steroid incomplete. And they found that there was benefit for overall days of ventilation, BPD, the hospitalization, and healthcare costs when the oscillator was used as compared to the ventilator. So I guess that's another point to think of, that each device should be used for specific indications, maybe, rather than making a blanket statement that all babies will respond to it. You kind of hone down onto the population where you can make the maximum difference. Future directions. One of my pet peeves still with the oscillator is that after being in existence for so long, we really have not paid much attention in trying to figure out, is there a way of measuring tidal volumes? Because just getting those x-rays are not really helpful, and then you are exposing the babies to a ton of radiation. So if there are ways to actually measure the tidal volume, that would be awesome. These methods are available, can be done, but they are not ready for prime time bedside use. The combined ventilators like the Draeger vent is able to give some measures. It gives you the CO2 measures the device itself. But again, this is not approved in the US right now. I know that they're working on trying to get FDA approval for it. So just want to kind of share some of the work that we've done. This was the graph on my left panel here is kind of showing that you can actually measure tidal volumes. You can actually get the hysteresis loops on the oscillator, but then it needs a special tube where you can actually measure the tracheal pressure. You need other devices to then translate those waveforms into the actual loop, and that makes it really, really cumbersome. In one of our unpublished work, hopefully that's going to be out soon, we looked at, is there a way that you could just use the parameters on the oscillator currently and then calculate the volumes? So just by looking at the bias flow, the mean airway pressure, the amplitude that you're setting, you can actually look at the parameters, the resistance of the airway, the compliance, as well as the lung volumes. And so hopefully we will be able to kind of translate that into something that is usable for the clinicians at the bedside. And with that, I want to thank everyone. That's Max, one of my favorite patients of all time. And I'm happy to take questions.
Great. Thank you so much for that wonderful talk, Dr. Singh. I went ahead and put in a red cap link to the evaluation form for us. Please take a moment to fill that out. It helps the series, as well as feedback for Dr. Singh. I'll go ahead and ask some of the questions in our chat here. So our first one is, in your experience, other than a chest x-ray, what other reliable indicators have you found to know that your MAP on your oscillator is too high? And someone in a follow-up question asked if NIRS would be helpful. So both those.
Yeah, great question. So again, x-rays are very, very crude at this point in time. And the way that you can figure out whether your mean airway pressure is really high is looking at those clinical parameters that I had mentioned earlier. Your blood pressures are going soft. Your SATs are actually going in the wrong direction. Those are the things to watch out for carefully. And as you back down on the map, you realize all those parameters improve. So I like to rely more on the actual clinical bedside numbers than just one film that I've shot in a moment in time. As far as NIRS goes, NIRS has a lot of positive value. Having said that, it really, again, has not really translated into anything clinically, whether it is in monitoring and prevention of IVH, the SAFE booze study trial. There are 3 of those that looked at the parameters to see if we could make a difference in the outcome. So you could look at the cerebral flow and the gut flow, but not sure that that really helps you tie into how you can manage your ventilator support. Because is the NIRS really giving you the fact that the cardiac output is decreased, or is there something else that's going on in that brain where the flow is being, or the measures that you're looking at are being impacted? So again, it's a promising device. Again, very difficult to translate at the bedside when the probes cost you an arm and a leg. So I would say that it has value, but has really not translated into real-time management as far as current work has gone. Let's see.
Perfect. Another question I'm seeing here is that some people have noticed that when they change the map on their oscillator, the transcutaneous, so the TCOM, CO2 tends to increase, and they're wondering, and vice versa, and they're wondering if you could help explain that mechanism between why changes, or how changes in map would change your CO2 essentially.
Yeah, again, a great question. The map obviously is primarily, as I said, used for the purpose of oxygenation, but even for ventilation, you have to have adequate recruitment, right? If you're backing off on the map, are you de-recruiting some of those alveoli that are helping you, maintain the lung compliance and helping prevent the mismatch from happening? So there has to be a good reason why you're weaning down the map on a baby, not just because my FiO2 is stable, I'm going to wean down. If backing off on the map is increasing your CO2 because you have de-recruited the lung, then you really should just go back and stay put for another 24 to 48 hours before you try to push the baby off it. Again, to my younger colleagues and trainees, I'll make it a point that patience is very important. Just because you can do something every single day doesn't mean that you have to do it. The babies will let you know when they're ready to be backed off or weaned off of any mode of ventilation that you're on. So if you're seeing that happening, it's just a factor that you've de-recruited and you've caused a VQ mismatch to happen.
And I know we're at the top of the hour, but I'll do one more question here. So traditionally, it seems like oscillator training has suggested not to change that I to E ratio and to maybe stay with the 33%, which may be safer. Any insight into when it might be good to change that, or what kind of prompts you to do so?
Yeah, again, really lovely question. And that's where I will recommend to everybody, find your respiratory educator, pick up an oscillator, plug it in, not on a baby, just plug it in and play with it. You'll notice that you can go as low as 5 hertz, you can go as high as 18 to 20 hertz. You can drop your, or you can play with your eye time, ranging between 33 to 50%, and see what the abilities of the machine are. Traditionally, you're absolutely right. When the oscillators came in, the thought was just play with a couple of things and leave the finer things out. It's similar to conventional ventilator, right? When I ask our group or somebody who's starting afresh, hey, what is the eye time? And they're like, eye time? I didn't tell the therapist to fix the eye time. Or what is the sensitivity of the vent? Oh, is there something called sensitivity? So there are a lot of different parameters within the different devices that we have that we've kind of stayed away from. 90% of the times it'll work for you, that you don't have to change anything. You will be able to do it with just the 33% eye time that's set on the oscillator. But there are times where you might want to tweak that because you don't want to really jack up your map or jack up your amplitude to numbers that you are not happy with. And just tweaking that eye time can actually make a big difference, both for your oxygenation and ventilation. One of the references that I have in here is actually a lovely handout from that comes with the Draeger log, and Professor Peloya, this one. Professor Jane Pillow out of Australia, who's done some really cool work in the oscillator. She's put together that kind of bit of a manual. So I would strongly recommend for people to look at it and read it. And therein it talks in way more detail than I could do in the 45, 50 minutes that I had here about the value of looking at the eye time.
Perfect. All right. Thank you so much again, Dr. Singh, for taking the time to talk with us. Thank you, everyone, for tuning in. Again, if you can take a minute to either scan that QR link there on the screen or click on that red cap link and submit an evaluation, that'd be very appreciated by our team.